Okay. So now we look at factors affecting GFR. This is an important UQ and comes as such in your SAQ component of the exam. Okay. So I will assume that you know what these mean, Starling forces. Okay, so I'll just briefly jog your memory. When you did circulation in first year, uh, they must have talked about, and you must have studied the forces acting across a typical capillary system. Okay, so there are forces which would push the fluid out, and there are forces which want to keep the fluid in. So if quickly you can answer, what would hydrostatic pressure of the capillary do? Is it a pro-filtration force or anti-filtration force? If your answer is it's pro-filtration, you're right. It tends to force fluid out of the capillary. What about plasma colloid osmotic pressure or simply oncotic pressure? What does that do? Again, if your answer is it keeps the fluid in the capillary. So in that sense, it's one of those forces which goes against filtration. You are correct. These are the two forces which act across all capillary membranes, and hence glomerular capillary membrane is no exception. In fact, here the hydrostatic force is more than hydrostatic pressure elsewhere. So these are the Starling forces which basically cause GFR, if you know what I mean. This is how filtrate is born, quote unquote, is formed. Okay, these Starling forces force fluid out, mainly the hydrostatic pressure, out of that capillary, and hence filtration fraction is formed. Okay, now how is filtration what affects Starling forces themselves? So once again, Starling forces basically make GFR. They make the filtrate, and they in turn get affected by the amount of renal blood flow that is coming in, and afferent and efferent arteriolar resistance at any given time. So these two factors, they affect Starling forces, and Starling forces, being the generator of GFR, then affect GFR. Okay, this is the sequence of events. So when you are asked about factors affecting GFR, you mention Starling forces. Maybe in brackets you want to say which in turn get affected by changes in renal blood flow and resistance of the glomerular afferent and efferent capillary network. And number two, this quotient, glomerular capillary quotient, or KF. We will talk about this as well. So this slide is the main slide when you're talking about factors affecting GFR. So now we get this overview of Starling forces across the glomerular membrane. As I mentioned, look, this is a simple schematic. It shows the afferent arteriole, the glomerulars, and the efferent arteriole. Okay, and in the glomerulus, he is showing glomerular hydrostatic pressure, and it shows it's 60 mmHg, which, if you remember, is around 30 to 35 in a normal capillary network. So this is clearly significantly higher than your average capillary network. And then he shows oncotic pressure, colloid osmotic pressure. The values are here. And then outside of this glomerulus, you have the Baumann capsule, where he shows pressure. He just says capsule pressure. Basically, this is a hydrostatic pressure. So first, just focus on these three. If you remember the discussion of Starling forces in circulation, you would remember that there is a fourth one. So there is hydrostatic pressure and colloid osmotic pressure. Then there's hydrostatic pressure. What about the colloid pressure in the glomerular capsule? It's not mentioned here. We'll talk about this. So under this pressure, this hydrostatic pressure, high pressure, filtrate plasma basically goes out of the glomerulus and comes in the Bowman capsule, and that filtration fraction that we talked about, that is born, okay, that is formed, and that causes the Bowman capsule pressure to also increase. So this pressure basically is because stuff is coming out of this capillary and collecting here, very importantly, temporarily, okay, because remember what is beyond this boundary here, it's the tubule. So it's going to stay here for a bit only. It's continuously being drained. The fluid comes out and is drained into the tubule, the renal tubule, and so on. So the temporary rise of pressure here is around this value. However, whatever this value is, it does tend to oppose, because it's a hydrostatic pressure. It would put some sort of resistance to the outcoming of the fluid out from the glomerular capillary. Okay, and hence there is a equilibrium in these two pressures. As you remember, oncotic pressure or colloid osmotic pressure is exerted by plasma proteins, and since they are colloidal in nature, they would like to keep a hold on their fluid and not let it go. Hence, it's an anti-filtration pressure, and its value is 32 mmHg, i.e., this is the pressure that the plasma proteins exert within the blood so that it doesn't the fluid doesn't go out. Okay, so in the face of this pressure and this pressure, again there is a balance here, which keeps the formation of filtrate relatively constant. Now, coming to the point, where is the oncotic pressure of Bowman capsule? Question mark, question mark. So basically, uh, we don't have it, because if you remember, we have a double membrane structure here. Okay, and a double membrane structure means that we will not allow macromolecules to come out beyond this filtration barrier. Okay, hence it's very unlikely that any protein would come out and roam around the Bowman capsule. Indeed, it's only certain diseases which break this filtration barrier, and then you have a free fall of all sorts of proteins coming into the Bowman capsule. And in that case, it becomes operational that you need to then also consider Bowman capsule or oncotic pressure. But normally, it should be so less that it's negligible. We don't even mention it. Okay, so when you calculate the net filtration pressure, which obviously is in favor of the hydrostatic pressure, so obviously looking at cursory look at these numbers would tell you that stuff should be coming out mathematically. You just use this equation. You put in the glomerular hydrostatic pressure, you subtract the Bowman capsular pressure from it, and the main force. These two are anti-filtration. You just subtract them from the one pro-filtration force, you get a value of 10 mmHg. And this 10 mmHg, remember, is it looks like a small figure, but it's not. It is a continuous process. It's the pressure at which continuously 180 liters of your plasma is going through these glomeruli of both kidneys, and at a constant pressure of 10 mmHg, stuff is coming out. It's the sheer amount of blood that goes through this network that makes this apparently small amount of pressure, it actually has a huge consequence, if you know what I mean. So Starling forces is basically the generator of filtrate. Now, Starling forces in turn get affected by, very rationally speaking, the amount of blood that you make available to them. Look, Starling forces would not be there if blood doesn't arrive inside the glomerulus. The Starling forces are things which are in the blood. So blood exerts an hydrostatic pressure. That's a Starling force. Blood has oncotic pressure, that is again by virtue of blood being there. So what makes the availability of blood in the glomerulus is two things: the rate of glomerular blood flow, i.e., how much are you allowing the blood to come in, and the second, which basically, if you really look at it closely, is related to RBF, is the resistance. So it's the collective or individual resistance of afferent arteriole and efferent arteriole which will determine renal blood flow. Okay, so, i.e., what amount of blood is coming into the glomerulus, and this in turn will effect, with an E, Starling forces. So it's the resistance of the capillary network affecting renal blood flow, which affect Starling forces, which are forming GFR. Okay, it's in this sequence if you really want to uh, study it as a linked process. So these are the three scenarios, but before going into them, let me just introduce you to this learning method. So what he shows is an afferent arteriole, glomerulus, and then efferent arteriole. The rest is very labeled very clearly. Now look at this. To show you the resistance, he just shows this nice little analogy of a screwing mechanism. And if you tighten the screws, this constricts and hence the resistance increases. So if you can imagine, you can have a mechanism which constricts afferent arteriole. You can have you have a mechanism by which you can constrict the efferent arteriole, or both. Okay. So now let's first look at what happens if you increase the resistance of the afferent arteriole. Now, if you see, and it's very clear that whatever the feeding artery was, when it formed the afferent arteriole, the flow of blood to the afferent arteriole in this situation where you have increased the resistance of afferent arteriole, the blood coming to this side will decrease, and hence the glomerular flow of blood will decrease in this example. So increasing the resistance of afferent arteriole, or in simple words, vasoconstriction of afferent arteriole, will decrease the RBF, the renal blood flow, which will decrease the GFR, right? What is the agent, which agent of the Starling forces affects this decrease in GFR? The hydrostatic pressure. Naturally, less blood, less RPF in the glomerulus, less capillary hydrostatic pressure, which is the main filtration agent, and hence less the GFR. Okay, this is very clear and simple. This, however, is a bit more complex. Uh, Increased resistance of the efferent arteriole. So in this example, remember these are very important viva questions, and MCQs are formed here on this, based on this material. So in afferent, you just vasoconstricted the afferent arteriole. Here, you vasoconstrict the efferent arteriole. Now this has all sorts of consequences. So don't be confused by this. We will explain it in a bit. So imagine that normal blood was passing through. Now I'm explaining this scenario here. Okay. Normal blood was passing through the afferent in the glomerulus, and then blood was being drained out of the efferent arteriole. 20% filtration fraction was being formed, as we studied, at the glomerulus, and the 80% of blood was escaping through the efferent arteriole. Now what you do is you vasoconstrict the efferent arteriole mildly. You see, there is a complexity here. There are two sub scenarios in this scenario. One is mild constriction of the efferent arteriole, and then there is a severe constriction of the efferent arteriole. First, let's work out the mild constriction. Now imagine, if the efferent arteriole is mildly constricted, what will happen to the blood flow? The blood flow would decrease. You have just increased the resistance of the escape vessel. So obviously, and you haven't done anything to the, very importantly, you haven't done anything to the afferent arteriole. It's the same. So if you, in this whole system of blood coming here and through this and then escaping, if you increase the resistance here, what you are doing is you are trapping blood in the glomerulus. And then you are also, by trapping blood here in the glomerulus, you are basically decreasing the fresh incoming blood, right? Because there is damping of blood here in raising the hydrostatic pressure. So the incoming blood, the delta P would decrease, and blood coming into the glomerulus will decrease eventually when effect of this efferent vasoconstriction takes place. I hope this is clear. Under this increased hydrostatic pressure, GFR will increase. I'll say it again in one sentence. In mildly vasoconstricting the efferent arteriole increases GFR by increasing the capillary hydrostatic pressure. However, overall, the renal blood flow has decreased in this scenario. Okay, very important. This can be asked in a tricky way by the examiner. He can ask you, give me a scenario where renal blood flow decreases, however, GFR increases. Now, to the unprepared student, this can be a very off-throwing question, because rationally speaking, for GFR to increase, you need to have increase in renal blood flow. That's the straight equation, right? But in this particular efferent arteriole scenario, which I told you is tricky, what happens is it does increase, GFR increases, but the overall blood flow through the whole system has actually decreased. And you know now what's happening. Okay, so we've done the mild vasoconstriction. What about severe vasoconstriction of the efferent arteriole? What happens then? So it's not shown here, but if you really constrict it, seriously constrict it, almost occlude it, what will happen? What will happen is renal blood flow will further decrease, yes, and the blood trapped here will have nowhere to go. Okay, when it has nowhere to go, it will become static here. There is stasis, no flow of blood will take place. Now, the initial increase in the hydrostatic pressure, which resulted in increased GFR, obviously it will have a limit because there is no fresh blood flowing inside. Imagine that the blood trapped here is just trapped, because and now the efferent arteriole constriction is so severe that it cannot really move at all. So the stuff that had to be that could be filtered out has actually filtered out during the mild efferent constriction phase. That filtrate part has already become GFR. What is left behind is less liquidy portion of the blood and more cellular portion of the blood. So the hematocrit would increase, won't you agree? You have removed already the filtration fraction, leaving behind the blood is thicker, quote unquote. Hematocrit is more. So which pressure will increase in this situation? Which stalling force will increase? If your answer is colloidal osmotic pressure will increase because plasma proteins will be concentrated per unit of blood, then your answer is correct. And because of increase of colloid osmotic pressure, eventually the GFR will decrease. I'll say that in a sentence. So increasing efferent arteriolar constriction severely raises the plasma colloid osmotic pressure of the glomerular capillary blood, decreasing GFR in a scenario of decreased renal blood flow, severe decreased renal blood flow. Okay. Now, final point is saying it in one sentence. This is called the biphasic effect, Biphasic, biphasic, i.e. two phases. So in efferent arterial vasoconstriction, mild efferent arterial constriction leads to increased GFR, while severe efferent arteriolar constriction leads to decrease in GFR. Okay. That's done. I hope you understood that. Uh, a final point here is this is not a theoretical exercise. Actually, what happens is a chemical called angiotensin 2, and we'll talk about this in this lecture later on. Angiotensin 2 is something that is formed in the blood, and since it's formed, obviously, while it's forming, its amount in the blood is at first is low, okay, and it's a vasoconstrictor, and it sort of likes the efferent arteriole more than afferent arteriole. So initially, even at low plasma concentrations, it has a vasoconstrictor effect on the efferent arteriole, and as its amount in the blood raises further, the amount of vasoconstriction, the degree of vasoconstriction increases. So at high levels of angiotensin 2, the efferent arteriole really chokes up, which we mentioned that it is severe in vasoconstriction. So let me now say it in a sentence which mentions angiotensin 2. At low concentrations of angiotensin 2, brackets, mild vasoconstriction of the efferent arteriole, GFR is increased, right? While at higher angiotensin 2, in brackets, severe vasoconstriction of the efferent arteriole, GFR is decreased. Okay, hope that is clear. This scenario you need to work out yourself. We have actually dilated the afferent arteriole while the rest is constant. What will happen to the stalling force? What will happen to the GFR? And overall, under what value would renal blood flow would be? I would look up the comment section below for students who work this out. Okay, so having dealt with Starling forces, number two is filtration quotient. Filtration quotient, very simply put, is basically the overall status of your glomerular membrane. What is its permeability? So there are conditions, diseases in which this permeability decreases, and then there are other inflammatory diseases being one of them, which may cause an increase in permeability of the glomerular membrane, capillary. You can imagine if the permeability, say, increases, then the GFR would increase, right? Multiplied by surface area. So there are diseases in which there is loss of glomerular membrane. So in that the surface area actually has decreased. So if you have a decrease in area of surface area across which the filtration is happening, naturally the GFR would decrease. It's just like the respiratory membrane, which you studied under respiratory physiology in first year. If you have a normal respiratory membrane surface area, the alveolar exchange of oxygen and carbon dioxide is normal between blood and alveoli. But if you have a decrease in surface area, then you will have decreased ventilation and decreased gas exchange. Same is the case with permeability. If there is a gas in respiration, if there's a gas which has more permeability, it will go across more. If it has less permeability, it will go across less. So filtration membranes physiology and respiratory membranes physiology is very similar in terms of its physics. This is a normal value of Kf 12.5. Look at the very interesting unit here. So it's milliliter per minute per unit pressure. Okay, so it encapsulates both of these factors.